It's still pending. Let's have a look. There we go. We're live. Hello, everyone. Thank you so much for your patience. I can see we've got a good crowd online tonight. Yeah, thank you for your patience. We were having a few issues with the technology on our end, but it's resolved now. Delighted to have you with us for a sort of short revamp of the neurology series that we previously run for Mind the Bleep. All our previous stuff from last year you can still look at on the Mind the Bleep website and YouTube. Tonight we have got Dr. Zeeshan Yousuf, who is a neurology registrar at Universities Hospitals Plymouth in the southwest of England, who I have actually worked with previously, unlike the rest of our speakers who I've only met online. Zeeshan's going to talk to us about neuromuscular disorders tonight and everything you need to know as a sort of F1 or SHO grade. So without much further ado, I will hand over to Zeeshan. Feel free to type in the chat. We'll send you some feedback at the end and you should be able to get a certificate automatically. You put in that feedback. But for now, Zeeshan, it's in your capable hands.
Excellent. Great. Thank you, Alex, for giving me the opportunity. I'm one of the registrars in neurology, stroke medicine, and general internal medicine. I'm currently working with University Hospital Plymouth. And the topic of my today's presentation is neuromuscular disorders. I might be explaining too much in detail about some of the neuromuscular disorder because I've seen some good cases, especially one of the cases which we are going to discuss today in this presentation. So I'll be touching on different pathologies related to neuromuscular disorder, especially to the disorders of the muscle itself. However, since it's a very big topic, I will then, my first part of the discussion will be basically to touch base with the common disorders that on the level of FI1, FI2, and SHO level should know. And on the other hand, I'll be explaining to you one of the interesting case. And there will be very fine details that you might be able to, you guys might be able to get into practice and have some revision about these pathologies. So that one case report will cover so many things as well. So let's move towards, as I said, my topic is basically neuromuscular disorders. So what are neuromuscular disorders? They are the disorders of the nervous system and the muscle itself, and these disorders can result from problems with the nerves that control the muscle movement, which is motor neurons, the muscle themselves, or the neuromuscular junction. Neuromuscular disorders can be acquired, it can be genetic, and the severity also varies, and the symptoms also varies as well. And some of the common categories and examples of the neuromuscular disorders are as follows. The most famous one, the most common one, is the motor neuron disease. Whenever we think about neuromuscular disorders, the first thing that comes in our mind is a motor neuron disease. And of course, it is not very rare. It's very common actually that we see a lot during, especially our attending weeks and in the hospital as well. So motor neuron disease, it is a broad term, and it has got two subdivisions of the motor neuron disease. One is the ALS, which actually includes upper and lower motor neuron signs. Usually the patients have muscle weakness and atrophy. And the other one is basically the spinal muscular atrophy, which is a genetic disorder, and it is characterized by low motor neurons in the spinal cord, resulting in a muscle weakness and atrophy. We have got some peripheral nerve disorders, which my colleagues have covered in the past, which can also lead to muscular disorders. So, for example, peripheral neuropathy, that nerves that are damaged due to infections, diabetes, or autoimmune conditions. And the other one is GBS, which is also famously one of the autoimmune disorder that affects the peripheral nerves that leads to ultimately muscle weakness and leads to paralysis. And we all know GBS has got a very strong correlation with diarrhea and infections. The third one of the neuromuscular disorder is a muscle disorder, which I will be focusing on, which are called myopathies. And it's a very broad topic, so I'll try to cover as much as I can. Now, what are the muscle disorders? What are the myopathies? So muscular dystrophy is one of them. It's a genetic disorder, and it's characterized by progressive muscle degeneration and weakness. And the example includes Duchenne and Becker's muscular dystrophy. And the other division of the myopathies or muscle disorder is the inflammatory myopathy, for example, polymyositis and dermatomyositis, which we are going to discuss in our next slides as well. Some are neuromuscular junction disorders, for example, myasthenia gravis, which we also commonly see in our clinical practice. These are autoimmune disorder in which the immune system targets the neuromuscular junction, and that leads to muscle weakness, particularly in face and in the neck, and leads to some bulbar type of symptoms. Some metabolic disorders sometimes leads to neuromuscular disorders as well. And some are mitochondrial myopathies that affects and causes the muscle weakness. Some are channelopathies, for example, periodic paralysis, for example, potassium channel induced or hyper or hypokalemic periodic paralysis leads to muscle weakness and paralysis. And lastly, movement disorders such as Huntington disease. It's a neurodegenerative condition, but of course it affects the nerves and muscles and leads to muscle control disorder. Now, as I mentioned, that I will be more inclined towards the muscles disorder itself, which is a myopathy. So I'll be discussing different type of muscle disorders that we usually see in our clinical practice, in our emergency departments, in clinics mostly. So, number one, which is very common and we all should know about, and usually comes in the exam as well, it's polymyositis/dermatomyositis. Now, what is this basically? It's basically an inflammation, and it's usually symmetric. That's very important. It can be subacute. It can be, usually it's proximal as compared to distal, and shoulder and hip girdle. They are the ones that are mostly affected. Dermatomyositis usually is seen sometimes in adulthood, sometimes in childhood, but polymyositis is very rare before the age of 18 years. There are some skin changes as well, and of course, heliotrope rash, which is on the eyelid, edema, and purplish discoloration on the eyes is very common in this condition. Gottron papules, which is basically the papular rushes over the knuckles, is very commonly seen. And of course, it is associated with malignancy, lung malignancy, and sometimes associated with interstitial lung diseases. Now, whatever I have mentioned we'll be discussing in the case presentation, which I'll be explaining in the future in my next slides. Now, in poly and dermatomyositis, how we investigate if we suspect someone, what are the laboratory tests that we should do? Now, creatine kinase, of course, is a muscular disorder. So creatine kinase is moderately or severely elevated. EMG will show myopathic pattern, and anti-MI, anti-JO, and anti-SRP antibodies can come back positive. Although these antibodies are not 100%, but 50% of JO antibodies are seen in interstitial lung diseases come back positive. We also, of course, as mentioned, that's poly and dermatomyositis. They're usually seen in the patients who have got either malignancy or interstitial lung disease. Pulmonary function test should be done in these patients. So this is how we should initially approach the patients with this condition. Now, what's the pathophysiology? What's the histopathology? So as I mentioned, that mostly is associated with malignancy. 6 to 45% associated with dermatomyositis. Malignancy associated with dermatomyositis. Although some connective tissue disorder, for example, rheumatoid arthritis, Sjogren's syndrome, SLE, they are also associated with these connective tissue disorders. Now, in histopathology, we can find in dermatomyositis, we find perivesicular atrophy, and we also find inflammation, which is a perimycal and perivascular inflammation. And we sometimes find membrane attack complex deposition on the blood vessel. In polymyositis, we may find some endomysial inflammation invading non-necrotic muscle fibers and endomysial CD8 T cells. And these are basically found on the muscle biopsies, basically. These are the findings that we find in the muscle biopsy. How we treat the patients like these? Steroids, methotrexate and azathioprine. Sometimes we need IVIG and plasma exchange, and very rarely we use rituximab. Usually the initial mode of management is steroids or IVIG. Second one is inclusion body myositis. It is not as common as poly and dermatomyositis. Its usually onset is basically greater than 30 years old. It's male predominance, and it's asymmetric as if you compare it with the poly and dermatomyositis. And the most important thing, which usually is asked in the exams as well, that it where does it affect, or what is the pathognomic signs of suspicion of inclusion body myositis, is basically finger flexors, wrist flexors, and quadriceps. This is one of the common tested things that are asked in the exam tested questions. Dysphagia is not very common in inclusion body myositis. Now you can see here that CK is not a very specific. It's one of the. It could be a sensitive, but it's not a very specific in the muscle disorders, because in most of them it's mild to moderately raised. So CK is mildly to moderately elevated, and the EMG will show myopathic units, sensory nerve action potentials, often reduced amplitude. Can have antibodies against cytosolic 5 nucleotidase. The pathophysiology basically is it has got some association with autoimmune diseases. The histopathology is very important. You'll find rimmed vacuoles and mononuclear invasion of non-necrotic fibers. There's no effective treatment for inclusion body myositis, and usually we start with the steroids, but immunotherapies like rituximab, azathioprine, they are not very responsive to inclusion body myositis as compared to poly and dermatomyositis. The third one is a very busy slide, but this is the most important slide for muscle disorders. Acquired myopathies. There are many conditions that can affect the muscles, and I'm trying to make the base of this before I jump to the case presentation, is because we should know about, in our clinical practice, when the patient comes to the hospital, what things should be observed, what things should be connected when the patients are coming to the hospital with weight loss, with muscle loss, with muscle weakness. We receive so many calls in our day-to-day setting from junior doctors as well, and of course from different staff members as well. When the patient comes to the hospital and there's a weakness, the first thing comes into mind is a stroke. Stroke can be a cause of muscle weakness, but there are other causes as well that can lead to muscle weakness and subsequently lead to muscle loss. So apart from motor neuron disease, which is very common, apart from other disorders of muscle, metabolic causes are very, very important, and they are missed a lot. So starting with acquired myopathies, we have reviewed poly and dermatomyositis and inclusion body myositis. The most important one among all of them is acquired myopathies. For example, the condition like amyloidosis, the accumulation of amyloid causes neuropathy, and it can cause symmetric proximal muscle weakness, so it can lead to myopathy. The other one, one of the most important one, is a critical illness myopathy. So patients who are on severe illness, patients who are in ITU, patients who have been in the hospital following accident for a long time, commonly these are the patients who can develop this critical illness myopathy. So what are risk factors for critical illness? Prolonged severe illness, corticosteroids, use of corticosteroids, association with neuromuscular blocking agents is unclear. Common causes of failure to wean from ventilator. What we'll find in biopsy you can find myofiber necrosis and absence of myosin thick filaments. The other causes are toxins, infections, and infections such as bacteria, virus, parasites, fungal infections. Alcohol very commonly can cause myopathy. There are medications very commonly known, statins, as we all know. It can affect the HMG-CoA reductase, and it can lead to myopathy. There are some other medications, cyclosporin, amiodarone, antiretroviral medications, of course steroids, and antimalarial medications, and chemotherapy medications, which can also cause myopathy. And as I mentioned, some virus and bacteria and fungal and parasitic infections can affect the myopathy as well. There are some nutritional and endocrine myopathies, for example, thyroid disorders, hyperthyroidism, hypothyroidism, that can affect the muscles. And of course, diabetes can cause acute muscle infarction, and cortisol disorders, parathyroidism, hypoparathyroidism. So these are some of the metabolic causes. These are the acquired myopathies that sometimes are missed. And as a FI1, FI2, these are the common things that should be assessed when the patients are coming with a muscle weakness. And If it's a subacute muscle weakness, of course, if the patient is coming to the hospital with acute muscle weakness, then the scenario changes. But if it's a subacute, if it's like going on for weeks, or I would say months, then of course metabolic causes should come first as compared to the acute causes such as a stroke or other things or toxins. Okay, so we have got one of the important condition called Duchenne muscular dystrophy, and they are called muscular dystrophies basically, Duchenne and Becker muscular dystrophy. Now, Duchenne muscular dystrophy usually they are seen in children, and Beckers are seen in the adult. So Duchenne age of onset is 2 to 6. One of the pathognomic signs is a Gower sign, in which the patients try to sit up from the stand up from the sitting position by walking the hands up the thighs. It's called Gower sign. That predominantly shows as a proximal weakness, and frequent cardiomyopathy and conduction abnormalities are seen. Death usually takes place by second or third decade from respiratory and cardiac failure. Laboratory investigation will show CK 550 to 100 times normal. EMG may show myopathy. And of course, the histopathology will show necrotic and regenerating muscle fibers and increased connective tissue, and inflammation is usually mild. Treatment is supportive, and these patients usually develop these tendon contractures, so need more for support in that perspective. They sometimes develop cardiac diseases, respiratory weaknesses. There's no any specific treatment. I mean, we can treat it with the steroids temporarily, but it has got significant side effects, and patients usually have got not very good prognosis, especially with the aspiration and with other respiratory and cardiac failures. Death is commonly in second and third decades of life. Becker's, coming towards adult, it is a partial loss of dystrophin gene. It's an X-linked recessive disorder, and it is patient keeps on walking until the age of 15 by definition, but as the age progresses, their weakness starts. Histopathology will show similar to Duchenne muscular dystrophy, but dystrophin staining can relatively be normal. But the CK will be very, very high, and I think it's the giveaway is the Becker is usually seen in elder people, and Duchenne is seen in the younger group of children. One of the fancy one is Emery-Dreifuss muscular dystrophy. It's due to the gene that is affected. It's called amarin. Amarin is a nuclear membrane protein. I think in this kind of patients, usually they have got these tendon contractures in the Achilles tendon and the elbows, and there's a humeroperoneal weakness, and of course cardiomyopathy and conduction abnormalities are found. But I think the common findings are the contractures which are seen in Emery-Dreifuss muscular dystrophy, and it is one of the tested questions as well in the exams. Then we have some limb-girdle muscular dystrophies. This looks very complicated. However, I think there's a very interesting, not a patient. I saw a reality show in which there was a patient who had this rippling muscle disorder, and it was the show was basically related to, I think it was a kind of a talent show or something. And if you guys find time, if you guys have seen that show, that's fine. Otherwise, just find on the YouTube rippling muscle disease, and you will never forget caveolin 3 limb-girdle muscular dystrophy. So basically what happens is the muscles keep on rippling in this patient. So limb-girdle muscular dystrophy, they are of different types, but most of them have got cardiac conduction defects. So they're divided into two types: LGMD type 1, which is autosomal dominant, and LGMD type 2, which is autosomal recessive. For the understanding, I think what we need to remember is that LGMD1B is got cardiac conduction defects and it's got some contractures, and C is a rippling disease. Well, rest are also important, but I think for the stage of FI1, FI2, and SHO level, I think the commonly tested one are caveolin 3 gene that is affected in limb-girdle muscular dystrophy, causing a rippling muscle disease, and of course the lamin gene mutation that cause cardiac conduction defects. Now, the reason for touching base with all these muscular disorder was to discuss one of the case with you that I reviewed during my attending week. And I hope you guys find this interesting as well. So this is a 56-year-old gentleman who is got this previous history of alcoholic liver disease, has got ischemic heart disease, and COPD. He has got a history of medications that he take, include statins and aspirin and bisoprolol and carbamazepine. Social history-wise, he has got limited mobilization because of COPD, and he's a chronic smoker from past 40 years. He has got some asbestos exposure as well as a part of occupation, and he's chronic alcoholic. He has got no any family history for neurological disease. So basically, this guy who has got chronic alcoholism, he's a guy who's on statins, he's a guy who's got COPD, no family history of neurological disorder, came into the hospital, came in directly to the emergency department basically. The reason for the initial presentation was general decline. Symptoms was basically weakness in arms and legs. As we all see in our emergency department, the reason for coming to the hospital most of the time is the generalized weakness. There's no specific weakness, it's a generalized weakness. It's not a unilateral weakness, it's not one-sided weakness, it's not acute, it's a gradual 1 week history of weakness in arms and legs associated with problems with swallowing and some speech changes as well. He also had decreased oral intake, and he had some weight loss. From past 6 months, he's lost around 2 to 3 stones. So he was initially assessed by the ED team. On examination, he was alert and oriented. He was maintaining sets, but he was requiring 2 liters of oxygen. He was afebrile. He had difficulty in swallowing of both solids and liquids, and there was generalized muscle weakness. So till now, as you can see, there's nothing neurological that should be coming in. The initial investigations were done, and we found that CK is quite high. Creatine kinase was 18,000, but at the same time, you can see the liver functions are quite deranged. Now, AST, gamma GT, and ALA, they were high, but we all assume it could be due to cirrhosis of the liver because he's not diagnosed cirrhosis, but he has got alcoholic liver disease, and he's a chronic alcoholic, so we were suspecting it could be due to that. Magnesium was not very bad. It was 0.64. He had a chest X-ray, which showed some predominant emphysema. He's known to have COPD. And there was some opacification of right costophrenic angle, so we thought it could be an infection. CRP was not very high at that time, though. He was treated as pulmonary infection, given the hypoxia he was having. He was maintaining sets on 2 liters of oxygen. His statins were suspended because of CK that was very high. That's what we all should do. That if the patient's coming to the hospital with high CK, try to suspend those medications that can affect the muscles and also that can affect the kidneys. We gave some IV fluids, and patient was known to hepatic team already because this guy was having alcoholic liver disease. He was admitted to a hepatobiliary surgical ward since he was known to have ALD and he was having worsening liver functions. During this time, as always, he had a CT head scan. So when our patient comes to the hospital emergency department team, most of the times, if they're suspicious for anything, they sometimes do CT head scan, and most of the times they do find abnormality on the scan, but the CT head scan was normal in this case. It's very non-specific to have generalized weakness in arms and legs. So the localization doesn't match. MRI scan was performed as well. MRI whole spine was performed by the hepatobiliary team when he was admitted in hepatobiliary ward, and there was some disc degenerative disease was found, but there were old changes. There was nothing new. So once they were done with all these investigations and patient was still having dysphagia, swallowing difficulty, CK that was raised, muscle pain, they sent a referral to one of our team for ongoing dysphagia, speech changes, and generalized muscle weakness since admission. So when I assessed him, he was alert and oriented. His GCS was 15 by 15. His kernel of examination showed no ophthalmoplegia. There was no defect in central or peripheral field of vision. There was palatal muscle weakness. He was drooling saliva. There was dysphagia. He had marked mild difficulty in phonation and articulating the words, but he was not having any word finding difficulty. He had difficulty in articulating the words, and his phonation was basically affected. His cognition was not affected. Motor examination wise, he had generalized muscle wasting significant. Proximal muscles were affected in the upper and lower limbs, and there was tenderness to palpation in all the limbs. And in the upper limbs, the proximal muscle was 3/5, and distal, it was 4/5. Distal muscle weakness in the upper and lower limbs were reduced, but proximal were more reduced in terms of the power. I checked his fatigability test. It was negative. Sensation, reflexes, tone, coordination was normal. His gait was normal, and his gait was not performed because I was afraid he should not fall. So he was at risk of fall. So his gait was not performed, and his planters were downgoing. I don't know if anyone wants to say anything till now about what is going on with this patient. Any thoughts? I don't know how many people are joined here.
There's 24 other than us.
24. Okay. All right.
There'll be lots more on the live stream after or the recording after. So guys, type what you think in the chat about what might be going on.
Yeah, they can write in the chat. I cannot see the chat, so.
Oh, that's okay. Yeah, I can sort of say. Someone said polymyositis.
Yeah.
Which was also my thought, but I am similarly stumped.
Okay. Yeah. So I also thought the same. It could be polymyositis. It's not a bad start. So on my assessment, my clinical impression was it could be polymyositis, and the reason was because I was suspecting it could be underlying malignancy. And because he has got this history of asbestos exposure, he's smoking, he's taking alcohol, I was thinking it could be underlying malignancy, and ultimately he's leading to polymyositis and muscle weakness and CK raised. And my other impression was it could be drug-induced because he was on statins, so it could be statin-induced myopathy. But he has been taking statins for quite a while. It's not something which is new. He's been taking for a long, long time. His CK levels were high, his muscle weakness was symmetric, and there was a weight loss, and there's a suspected underlying malignancy, and of course, history of smoking and statin use. That's why it was my clinical impression. The other differentials that were coming in my mind was myopathies secondary to metabolic disorder. For example, alcohol can directly affect the muscles, endocrinopathies such as thyroid functions, and I was thinking about if it could be MND, if it could be lower motor neuron disease leading to muscle weakness, or it could be poliomyelitis, which is not very common in this part of the world. Lead poisoning or spinal muscular atrophy. Less likely, I was thinking it could be peripheral nerve disorder, but it was very low in my differentials, but more so it was more of polymyositis and steroid-induced myopathy. And of course, lesion in the upper motor neuron, for example, space-occupying lesion, acute stroke syndrome, demyelinating disease, infection, vascular anomalies were very last in my differentials because I was keeping these differentials as well because the patient was having bulbar weakness apart from the limb weakness. So my plan of management at that time was to start on methylprednisolone, 1 gram intravenous for 3 days, and send HMG-CR antibody that we usually find in patients who have got a statin-induced myopathy, as we have discussed initially. I sent the myositis screen for the patient for all the tests that we have discussed in the start of this presentation. I requested the nerve conduction studies and EMG, and depending on the NCS and EMG, I thought we'll see whether we need to do a muscle biopsy in this patient. So nerve conduction studies showed signs of severe polymyositis, but there was no signs of possible neuromuscular junction disorder. And we were quite convinced that it could be severe polymyositis and we should be treating this patient accordingly. On day 3 of intravenous steroids, his CK started improving from 18,000 to it became 10,000. Gamma GT also improved to 116 from 233. So since the symptoms were improving, we switched from intravenous steroids to the oral steroids. And we thought that we are going in the right direction in terms of diagnosis. So on day 5, we discussed with histopathologist, and of course he was scheduled to have a muscle biopsy. So this is a muscle biopsy result or slides of the patient that I reviewed in the ward. And the biopsy has been taken from deltoid muscle. And you can see here there's a pale necrotic area in the center of the muscle biopsy. And if you see here, this is also a necrotic fiber staining. And there's no deposition of membranatic complex. So I discussed with the histopathologist about what it could be. And he gave us the final summary of the muscle biopsy for this patient. He mentioned that there's no inflammation to support the diagnosis of myositis, and the features suggest acute necrotizing myopathy. And we should exclude toxic, drug-induced, metabolic, paraneoplastic, and immune-mediated causes of this patient. So initially we thought it could be polymyositis. Now the biopsy has come out to be something totally different. There's acute necrotizing myopathy and there's no signs of inflammation found. So it means that what we found on the nerve connection studies was different, and what we found on the biopsy report was different. So here, I'll mention about the neuromuscular disorder. I think it's I will go. Okay. I think we should go from here. Yeah. Now, what is necrotizing myopathy? So this is basically what the report found: acute necrotizing myopathy on the deltoid muscle biopsy result. Now, what is necrotizing myopathy, and why it is important in neuromuscular disorders, and what are the objectives that we should learn from this case. So what is necrotizing myopathy? It's a newly defined form of idiopathic inflammatory myopathy or myositis. It can also be referred to as necrotizing autoimmune myopathy. What happens in these is muscle biopsy shows much less inflammation in the muscle tissue than polymyositis patients, but they have increased evidence of muscle cell death or necrosis. Now, what are the causes of necrotizing myopathy? Let's talk about the symptoms. Symptoms are more or less the same. It's a weakness in the muscles closest to the center of the body, difficulty in climbing the stairs or standing from the chair, difficulty in lifting the arm over the head, and falling repeatedly, and difficulty getting up from the fall, and feeling of generalized tiredness. And then, in necrotizing autoimmune myopathy, there are some tests or there are some associations that needs to be done. For example, these patients are very prone to have HMG-CR antibody positive if they are statin exposed. These patients are known to have anti-SRP antibody positive. Some of these patients also have malignancy that is associated with them, or they are associated with connective tissue diseases. So these were then our 4 main objectives to rule out. In this case, following the biopsy result showing necrotizing autoimmune myopathy. So, as I mentioned, the biopsy mentioned necrotizing autoimmune myopathy. We sent HMG-CR antibodies. Now, what are the HMG-CR antibodies? It's a key enzyme. HMG-CR is a key enzyme that is used in the production of cholesterol. And patients who have anti-HMG-CR antibodies and use statin medications to control high cholesterol may unknowingly develop this type of statin-induced necrotizing myopathy. So we have to check this type of the antibodies against these receptors. Now, how does it work? So statin exposure leads to muscle injury that leads to increased regenerating muscle fiber that causes increased HMG-CR expression and in the genetically predisposed people of HLA-DR11, that leads to immune-mediated necrosis. It's one of the proposed pathogenesis of statin-induced necrotizing autoimmune myopathy. Now, the second antibody, which is also very closely correlated with necrotizing autoimmune myopathy, is SRP. So SRP antibodies appear in the blood tests in many in the patients experiencing necrotizing myopathy. And these patients also have cardiac involvement. Now, coming back to our case, we had to rule out these four causes following the biopsy result. Whether it's immune-mediated, whether it's toxic or drug-induced, whether it's metabolic, as we discussed before in our presentation, or whether it's paraneoplastic. We had to rule out these four causes causing necrotizing myopathy in this case. So we sent these antibodies. We sent HLA-CR antibody, it came back negative. We sent SRP antibody, it came back negative. And we sent myositis screen, as you can see here. We sent all the myositis screen panel, including anti-Rho as well, that came back as negative in this patient. Now, the second thing was to rule out if there's a toxic or drug-induced cause causing necrotizing myopathy. So, in this scenario, what are the toxins that could be causing this? So, for example, alcohol. He was taking alcohol. He's a chronic alcoholic. Cocaine. There was no any cocaine history with him. He was on lipid-lowering medications, antimalarials, he was not on, and colchicine he was not on. So patient was on statins. However, HMG-CR antibody came out to be negative in this case. There was no recent history of binge alcohol intake. When I took the history from him, he had a history of chronic alcoholism, but there was no any recent history of binge alcohol intake causing this significant clinical symptoms to be affecting, especially muscle loss and everything. And when he came into the hospital, there was no signs of rhabdomyolysis or AKI. He had a CK that was high, but his phosphate levels were normal on arrival. So, and we also sent some more tests to rule out if there's a metabolic cause of this necrotizing autoimmune myopathy, such as we checked his diabetic profile, his HbA1c was 32, that was normal. His glucose, potassium, calcium were normal. Thyroid functions and parathyroid functions were normal, and there were no systemic signs of Cushing's syndrome. So we are now having limited answers about what it could be and what is the cause of this patient's necrotizing autoimmune myopathy. We also send connective tissue diseases antibodies, such as we sent for MI and JO. They are basically for polyidermatomyositis. We send anti-SCL70, anti-nuclear antibody, DSDNA for SLE, mitochondrial antibody, smooth muscle antibody, and LKMA antibody, and gastroparasite antibody. They all came back negative. And we also sent some MuSK antibodies. They also came back negative as well. So the three most important conditions that can be affecting and causing myopathy is Sjogren's syndrome, scleroderma, and SLE. And seems to be they all were negative as well. We sent some paraneoplastic antibodies as well because cancer was also in one of our differential causing polyidermatomyositis. But the antibodies were negative, and at the same time we also sent some tumor markers. For example, CA99, PSA, and alpha-fetoprotein, and they all were normal. We sent some paraneoplastic antibodies, and they all were negative as well. Anti-HU, Rho, RI, MA2, and MP5, they all were negative. Apart from the blood tests, we also did radiological investigations in this case to rule out if there's underlying malignancy causing myopathy. And we performed a CT thorax when he came into the hospital. There were no signs of PE, and there was some emphysema, but there was a small nodularity on the lower lobes that was infective in etiology, nothing like a cancer. CT tap was done 1 month before admission due to weight loss and alcoholic liver disease. It was performed by GP, but there was no features of malignancy at that time. And he had a PET scan as well, and that was normal as well. But it was done, PET scan was done in 2021. And he had a PET scan after that as well when he was discharged from the hospital. So, since all the antibodies were negative, seronegative, immune-mediated necrotizing myopathy was considered as a likely differential for this patient. So now what is seronegative immune-mediated necrotizing myopathy? So we've got some articles about immune-mediated necrotizing myopathy. And the patients who have got HMG-CR antibody negative and SRP antibody negative, they are called immune-negative necrotizing myopathy. And this was one of the case of immune-negative necrotizing myopathy. I've gone through some of the literature search, and there has been some cases, especially one of this case, the autopsy case of antibody-negative immune-mediated necrotizing myopathy with severe cardiac involvement. It's one of the case in Japan Society of Internal Medicine. And there's one more case of a child who had all these antibodies done, nerve connection studies, antibodies, blood tests, and radiological investigations done, and at the end, the diagnosis was made as immune-negative necrotizing myopathy. Now, what we did after that, we did all these investigations. We realized that there's no antibody that is positive, but this gentleman is still declining, and he has got this muscle loss, he has got bulbar symptoms, and we have started steroids, but the CK started improving. So what we did was we managed him with oral steroids after completion of 3 days of IV steroids. We gave oral steroids for 2 weeks. His CK was significantly improved from 18,000 to 69 over the treatment course of 3 weeks. His dysarthria and swallowing difficulty was completely resolved. He was referred to one of our hospital for rehabilitation. And then I had a discussion with one of our neuromuscular specialists in my hospital, and she preferred to review the patient in her outpatient setting, and she basically switched the patient to mycophenol and mofetil, one of the immunosuppressant. He was awaited a PET scan till the time he was going to rehabilitation, but his PET scan was delayed because he ultimately developed COVID infection in the rehabilitation unit. So his PET scan, it takes months and months for the PET scan to be performed, and when the date arrived, he developed a COVID infection. So PET scan could not be performed ultimately. But of course, we had a PET scan of 2021, and there was no malignancy found at that time, although he was having weight loss since then. But there was no any dysphagia or clinical symptoms of dysphagia at that time. Okay, now, currently there are no randomized trials for treatment of necrotizing autoimmune myopathy, and the treatment recommendations are therefore largely based on expert opinion. Some people say that treat with oral prednisolone, 1 milligram per kg, for 4 to 6 weeks, or IV methylprednisolone, 1 gram for 3 to 5 days, is the first line of NM. Immunosuppressants such as methotrexate, mycophenolate, azathioprine can be added during the course of the treatment. And for refractory diseases, IVIG can be trialed, but there's no any clinical guidelines made for seronegative immune-mediated necrotizing myopathy. And there's one of the case report that also mentioned about seronegative necrotizing autoimmune myopathy with favorable response to IVIG. And of course, there are multiple other case reports who have mentioned that IVIG used as a monotherapy has got promising outcome. So the take-home message is that this case was unique because our patient had a history of statin exposure, and muscle biopsy found immune-mediated necrotizing myopathy. And we initially thought the diagnosis of statin-induced immune-mediated necrotizing myopathy. Our patient has negative HMG-CR antibody, and although the patient was not had a history of prior or current statin exposure, he still had an active myopathy. In addition, his suspected underlying malignancy, given history of ALD and liver lesions, may have been another contributing factor towards the diagnosis of seronegative IMNM. If there is suspected immune-mediated necrotizing myopathy, early muscle biopsy must be performed. So that's very important. And aggressive management with steroids and IVIG has shown better results. So it is a bit quite in detail that I went through the muscle disorder because I wanted to discuss this case with our junior audience. But at the same time, I wanted to touch base with these common causes of myopathies that I discussed in the start. So I hope that this discussion has helped you in opening the horizons of differential diagnosis in a complex patient when they come to the hospital. And first thing first is to rule out the basic things, um, and the common things, and then look out for the uncommon ones. So in this scenario as well, we ruled out the common things first in a patient with myopathy, and then slowly and gradually, when everything comes back negative, we found out something extraordinary. So that's my advice to all the juniors as well, to stick to basics and um, just rule out the common things first. Thank you.
Thanks very much, Zeeshan. That was really well. As someone who wants to be a neurologist, that was absolutely fantastic. Has anybody got any questions? Type them in the chat if you do. I've just put in the feedback in there as well. If you fill in the feedback, you should be able to get a certificate, and it's really helpful for us as well. It's definitely informed the way that we provide teaching in the past. So yeah, feedback, we do listen to it, and we do make modifications. I'll just give it a few seconds to see if anybody responds. If not, just to advertise that we have got 2 more sessions coming up over the next couple of weeks, before we sort of try and have a think about where to take the neurology series in general, as we've covered quite a lot of the topics that are the more common, and now we're moving towards more uncommon things, such as what Zeeshan's presented tonight. So it'll be interesting to see how the feedback develops. We've got another session on Parkinson's, which I think probably is one of our last sort of common condition sessions, and then we've got a registrar doing a session on neuroinflammatory disorders as well, things like MS and the sort of other chameleons and mimics that come up. Okay, I can't see that there is any questions being provided. Like I said, please fill in the feedback. But if we don't get anything in the next 20 seconds, I will take us off broadcast. You'll be able to watch this on YouTube. And yeah, like I said, thank you for coming. If you can provide feedback, it's really helpful for Zeeshan and myself. Anything else, Zeeshan, you want to say?
No, thank you so much for giving me the opportunity, and I thought that I should contribute at least a bit to our colleagues, especially the junior doctors. And of course, it started very, very easy and something that we have already read and understood for a long, long time since medical school. But in the end, it came out to be something totally different.
True. Yeah, I think in general, particularly the muscle disorders, I think medical school is very good at teaching you about myasthenia and Lambert-Eaton myasthenic syndrome.
Yeah.
But as soon as you get beyond the neuromuscular junction, even in the MRCP, it's essentially neglected beyond dermatomyositis, like you said at the beginning. So it's really helpful to have that comprehensive oversight. Anyway, right, I'm going to take us off broadcasting, and then feel free to drop any messages in. And thanks very much, Natalie. That's really helpful. And yes, like I say, it's good having a multidisciplinary audience as well. But right, we're going to shoot off, and we will see you